Good evening. My name is Chenza Kachadi, and I am the Family Engagement Coordinator at Kinark Child and Family Services. Welcome to this evening's family education session. This evening's topic is Understanding and Addressing Eating Disorders in Adolescents, a Guide to Basics and Treatments. Our family education series, developed in partnership with our Family Advisory Committee, is intended to build on your capacity as caregivers and professionals to identify, understand, and respond to childhood and adolescent mental health distress. During tonight's session, you will learn about different types of eating disorders, how to recognize signs and symptoms in adolescents. Relevant case studies and evidence-based interventions will be shared to learn about the journey from diagnosis to treatment and strategies and resources for families to support youth with recovery. There are a few housekeeping items before we get started today. All of your phone lines are muted and cameras are turned off to ensure a clear connection throughout this evening's session. We've set aside time at the end of the presentation to answer any questions that you may have. You can ask a question by selecting the Q&A icon, and a window will appear to submit questions. There is an anonymous feature if you would like to ask a question anonymously. Feel free to ask questions throughout the presentation so we can make sure at the end of our presentation we do have time to answer. And please note that we can only respond to general questions relating to today's presentation. Unfortunately, individualized advice cannot be provided, but we will try to respond to as many questions as we can. To ensure that we have time to respond to as many questions as possible, similar questions may be grouped together and answered all at once. At the end of the meeting, we will launch a poll to collect your feedback on the session. If you are having technical difficulties this evening, use the Q&A feature to report them. And we have launched our poll to identify the audience, so thank you for responding to that. And our presenters probably have polls at the beginning of our presentation. I would like to welcome our presenters, Sarah King-Audley and Zipporah Bernstein. Sarah has her master's in counseling psychology and is a registered psychotherapist. She has been supporting children and youth with mental health challenges and their families for about 6 years. During the past year, she has been a mental health clinician in the outpatient adolescent eating disorder program at Kinark Child and Family Services. And Zipporah, who likes to be called Zippy, and we love that name, is a certified diabetes educator and registered dietitian. She has been with the Kinark Outpatient Eating Disorder Program for the last year, and she has been supporting individuals with nutrition management to support their mental wellness throughout her career, including her past experience at Canadian Mental Health Association. So I suggest I turn off my camera so we can get into our presentation. So welcome, Sarah and Zippy.
Great. Thanks, Chenza, for introducing
us.
Yeah, and thank you to everybody who's attending tonight. Thanks for putting this time aside. Our hope is that we can increase awareness about eating disorders. Here's our agenda for the evening. We're going to flip to the next slide. We're both really excited to be here, and Zippy and I work together in an outpatient program for individuals, for youth and their families in an eating disorder program. And we really do have the privilege of working with the clients that we work with and spend time with. Before we get started, we'd like you to take a moment to complete the following poll. It'll come up on your screens, and just reflect upon a few questions before we get started. There should be I think there's about 4 questions in the poll. And I think they just come up one by one. I think maybe we can move on to the next question. If not everybody's answered, it's okay.
So we're actually going to get started by learning a little bit about some facts about eating disorders. This actually comes from the National Eating Disorder Information Center, which we will actually look a little bit at their resources and kind of what that website looks like at the very end. But nearly 1 are diagnosed with an eating disorder at any given time. That early detection and intervention are really kind of the most important things. And kind of, as we go through this, you'll be able to maybe recognize signs and symptoms a little bit sooner, just kind of learning a little bit about eating disorders and what that might look like and present in different people. Eating disorders often co-occur with other mental health conditions like depression, anxiety disorders, obsessive compulsive disorders, and substance abuse. Individuals with eating disorders are at a higher risk of self-harm and suicide. They also have the highest mortality rate among all mental health diagnoses. And eating disorders can also be associated with significant compromise in all of our organ systems of the body, including cardiovascular, gastrointestinal, our endocrine system, dermatological, hematological, skeletal, and central nervous system. So I think it really goes to show, the importance of kind of that nourishment of the body and how it impacts the entire body as a whole, not just, one part or another. Okay, so recognizing some signs and symptoms in adolescence. Now, there are a lot of symptoms, and it's honestly sometimes even hard to really compile a list of all of them. So these are kind of an idea of some of the most common ones. And as we go through our case studies, we'll highlight some of these as well, kind of more of a real life type of maybe situation. So drastic weight changes, this often happens very rapidly, and it's either a significant loss or gain. Excessive concern with body image. So constantly talking about body weight, shape, size, or appearance, maybe constantly kind of checking in the mirror what someone might look like. Excessive exercise. So not just, your typical 30 minutes a day trying to get movement in, but it's trying to make sure that we're burning off as much energy as possible. Very intense dieting restrictions. So very, very restrictive diets, eliminating typically entire food groups, or maybe there's a little bit of avoiding those social situations like birthday parties, maybe they don't want to eat cake or pizza or things like that. It's not those lifestyle changes of, I want to just eat some more vegetables, or, maybe I still want to enjoy pop, but maybe not as often. The avoidance of meals. So skipping meals, making excuses, again, that avoidance of eating with others, which kind of goes into that social withdrawal. So really kind of, not wanting to be involved with family members, friends, that might involve food or maybe body exposure. Mood swings, constant self-critique, social media use, that can be a very big kind of factor and driving factor and motivator. There's a lot of content out there, unfortunately, that can motivate youth, especially to maybe engage in disordered eating behaviors. Impaired concentration. So noticing at school, are the grades kind of decreasing in general, less studious, kind of comparing what it was before to, after, just kind of picking up on those signs. Maybe some memory problems, reduced problem solving skills, slower reaction times, the attention span might decrease, those obsessive thoughts. So really being very meticulous about really anything and everything, but especially food. And of course, those decreased energy levels. So always feeling tired, no matter how much they're sleeping, just that chronic fatigue and feeling weak. So now are actually going to move into our case study. So I'm going to pass it over to Sarah to do our first one.
Great. And I'm just going to let everybody know that Haley is not a description of a real client, but we've developed these case studies. We've kind of put them together based on typical situations within the context of eating disorders. So I'll be talking about this potential adolescent who is diagnosed with an eating disorder, and then we'll describe some information about her diagnosis, about the prevalence of the diagnosis, symptoms, and then we'll move into treatment while talking about Haley. So we'll start with this story. So a 16-year-old female, Haley, has been restricting food for 2 to 3 years. Most days she doesn't eat breakfast or lunch and then eats dinner with her family. Recently, she's been making excuses not to eat a full dinner or to avoid eating with her family. She doesn't want her family to know. She has difficulty eating in front of her peers and friends, so often doesn't eat lunch or won't eat with friends, has rules about eating, which include not eating meals that are above a certain amount of calories. She's probably always counting calories. She has foods that she won't eat. She finds herself constantly comparing herself to others, to friends, peers, her age, people she doesn't know. She scrutinizes herself in the mirror. She weighs herself every day and exercises in her room at night by doing videos. So recently, she's been feeling lightheaded and faint at school, went to see her family doctor. She shares with her parents that she has been having difficulty concentrating in class. Her doctor notices that her weight has significantly decreased and is now at about 85% of what it was a year ago. After speaking with Haley, her family doctor diagnoses her with anorexia nervosa, restrictive type. And you can imagine how difficult having that diagnosis in that moment might be for the youth, for the adolescent themselves, who may or may not realize that they have an eating disorder and, has been keeping this a secret for a period of time. And also perhaps for parents or family members, they might be shocked. They might not be surprised. They may have had a suspicion, but, it would bring up a lot for the entire family. In terms of the criteria for diagnosis for anorexia, the main criteria, and this is described by the DSM-5 as a mental health disorder, mental health diagnosis for anorexia, is restriction of energy intake, which is relative to requirements leading to significantly decreased body weight within the context of age, sex, height, and the developmental trajectory for that individual. So if you think of growth charts and having a child, put their height and their weight on their growth chart throughout their lifespan, we would see a trend of where that individual might be throughout their life. So a significant drop in where they've been on this scale is significant enough for us to see that there's been a significant change and would meet that criteria. So a key point here is the restriction of energy intake leads to a significant drop in body weight, but it may occur with somebody who appears to be lower than what you'd expect for their height, for their weight, or at a decreased BMI, but it can also occur for individuals who have a larger body size. So it may not be evident, it may not be something that others have noticed, and individuals who develop an eating disorder and have a larger body size often are undiagnosed for a longer period of time. So other parts of the criteria for diagnosis are an intense fear of weight gain, that preoccupation with weight, shape, and size, a distorted body image, so perceiving themselves differently than others see them, really having a dislike for even certain parts of their body or for their size. And the restrictive component of anorexia is that there haven't been recurrent episodes of binge eating or purging behaviors. So typically with an individual who has a restrictive type of anorexia, they may be using excessive exercise as a way, usually restricting what they're eating and using excessive exercise as a way to kind of decrease their weight. Risk factors for individuals to develop anorexia nervosa. The prevalence is higher for females, although it happens with males as well. Specific personality traits such as impulsivity and perfectionism are associated. And then having weight-related concerns for that individual that may come from different settings, may come from their environment. And then there's a biological predisposition. So often we're seeing clients who may have had comments made about their weight in, gym class, in extracurricular activities, in sports that they're involved in, and they have been more vulnerable to those comments, and they've been more susceptible to it contributing to the development of an eating disorder. So as Zippy mentioned, there's severe risks to emotional and physical health that affect all organ systems in the body. There's neurobiological changes that happen with eating disorders as well, that affect neurotransmitters, that affect anatomy of the brain, and this can lead to changes in thinking, cognition, and social functioning. So based on that, you can see this wide range of symptoms that an individual might present with. So the symptoms that Haley, who we're talking about this case, is presenting with is the restrictive eating, avoidance of certain foods. She has had weight loss. She has had amenorrhea, which is the loss of her regular menstrual period. She's experienced fatigue and weakness, cold intolerance, dizziness and fainting, and there's the list of other physical symptoms that an individual might experience. Distorted body image, depression and anxiety. And that can be a result of the neurobiological changes that occur, difficulty sleeping, extreme fear of gaining weight. And then the behavioral symptoms are the rules and rituals around eating, compulsive exercise, and this preoccupation with body shape, weight, and size. So treatment considerations for Haley, it's really important to take biological, psychological, and social environmental factors into consideration. And that involves ensuring that she has a comprehensive assessment done. And that would be a medical assessment, psychological assessment, and also an assessment that, takes into consideration how is she doing socially, how is she functioning at school, how is she functioning at home and with friends. Level of care required and intensity of treatment. We will talk a little bit more about this towards the end of the presentation. And so that reflects whether or not treatment would take place in the community, if it would need to be in a hospital, in a day treatment, or an inpatient setting. And a lot of that will depend on clinically what is indicated. Medical monitoring is always imperative when somebody has an eating disorder. So dependent on where the treatment is taking place, it may be a family doctor if the individual is in the community who's doing the medical monitoring, or it may be a physician who's part of, or a nurse who's part of a program. The multidisciplinary team is essential. So that could be made up of mental health clinicians, it could be psychiatry, dietitian, family doctor, or doctor, depending on the setting. And then concurrent mental health disorders is important to take into consideration, most commonly being mood and anxiety disorders. Obsessive compulsive disorders often overlap with eating disorders. And then also taking into consideration, is there a neurodevelopmental disorder such as autism spectrum disorder, or does the individual have ADHD? All of these will affect what treatment is decided and need to be taken into consideration. Motivation of the young person and the egosyntonic nature of the eating disorder. So egosyntonic nature of the eating disorder really describes that individuals who have an eating disorder may not acknowledge that they're sick. They may not acknowledge that they aren't well, and often are ambivalent because of this about accepting treatment. And this is really a symptom of an eating disorder. It's very common for individuals who have an eating disorder to minimize their symptoms, to rationalize or to hide some of the symptoms and behaviors that they are experiencing. And I would say that this is why it's really important for an individual to feel that they can be understood, that they're working with somebody who can empathize with what they're going through and can acknowledge how hard it might be for them as well. And sometimes that can help to increase some of the internal motivation. And then support for caregivers and parents, where, there's a high risk of caregiver distress and caregiver burnout with eating disorders. caregivers and families experience ongoing worry, stress, and anxiety and want the best for their loved ones. So finding ways to support families who are experiencing this is essential. So if we look back at, if we think of Haley and the description that was provided of her, we might decide that family-based treatment, which is called FBT, is the optimal treatment for her. It is the first line treatment. It's evidence-based for individuals who have anorexia. It's something that, of course, individuals have to consent to and have to feel that it's a fit for them. But it is all strongly recommended for youth who have had an eating disorder that has occurred for less than 3 years, and those who haven't necessarily been involved in family-based treatment before. So with Haley, she has not had previous treatment. It's a new diagnosis. This might be a good fit for her. And so I'll just go over the key principles of family-based treatment, family-based therapy. The first one, and this lens, I think this is common probably among the other eating disorder treatments that we'll mention tonight, is that we take an agnostic approach. And agnostic means no blame. So we're not blaming Haley. We're not blaming her that, this has occurred and that she has an eating disorder. We're not blaming her parents or her caregivers, her family. We're not putting blame on that. We're kind of accepting that this is where we are and we're going to proceed and, work towards recovery at this point. We may recognize that there's factors that may have contributed to this, but a main tenet to this type of treatment is not putting blame on the individual. Another piece of this specific to this treatment is externalizing the eating disorder. So we'll start to see and kind of identify and recognize the eating disorder as being separate from Haley. So if Haley is, thinking to herself, I'm not going to eat this. This is, there's too much fat on that steak, or, I can't eat the skin on this chicken, or whatever it might be, and vocalizes that, her parents or caregivers will help her recognize that that's not you, that's the eating disorder. So this type of treatment really separates the eating disorder from the individual. That's the eating disorder who's saying that to you, right? We take a non-authoritarian approach, which is really important for the individual youth to kind of accept this treatment and to agree to it. It really does need to be, it can be really hard. It can be really challenging at times. So it's really important to understand that and to provide that empathy and understanding. With FBT, the caregivers or parents are responsible for the renourishment of their child and for the weight restoration. So there's 3 phases of treatment. In the first phase, the parents are responsible for planning, preparing, plating, all of the food. There's supervision during meals. So somebody would eat with Haley during meals. And that's the first phase of the treatment until she would become hopefully renourished and back to the weight that we would expect her at. And then we would move into the other phases, which really work towards working more collaboratively and the young person having more autonomy and more choice. If we look at some of the other evidence-based treatments that are utilized frequently in eating disorders, CBT for eating disorders, which is called enhanced CBT, occurs usually over about 6 to 12 months. And it's a little bit different in the sense that this type of therapy addresses the thoughts and the beliefs that are maintaining the eating disorder. So we are not externalizing the eating disorder at this point from the client. Instead, we're trying to understand what the function of the eating disorder is and what is maintaining it and encouraging it to kind of continue and to work on developing other ways of coping with stress, other ways of coping, whereas the individual may have been using the eating disorder to cope. DBT is an intervention that's evidence-based that's often used for individuals who have severe emotional dysregulation, who have thoughts, urges, or behaviors for self-harm and suicidal ideation. And there has recently been some research done on its use in eating disorders, and there's been some promising results. So DBT is a treatment or method that can be used or can be pulled from and use, bits and pieces of it in eating disorder treatments. The last one that we've noted here is emotion-focused family therapy, which is a family that involves working with family members, and it helps to strengthen empathy for parents and caregivers and understanding, and really helps to strengthen those relationships within the family. So the overall treatment goals for somebody like Haley would be for us to renourish and then maintain that wellness weight, would be to increase overall health and wellness. So we really try not to focus on numbers and try not to focus on a weight number. Instead, we're working towards health, wellness, decreasing those symptoms that she was experiencing, her starting to feel more like herself. We want to decrease those eating disorder related thoughts, beliefs, and behaviors, and improve psychosocial functioning and support the development of the individual's identity without the eating disorder. If you think of an adolescent, this is a time of individuation, right? Where they're becoming themselves, they're, making decisions about who they are as an individual. We want them to be able to continue with that normal stage of development. And so we're promoting independence that's appropriate with the age of the individual around eating, around the planning, preparation, plating, and them taking control over ensuring that they continue to nourish themselves, and that these are kind of changes that hopefully will be long term. Okay, so we talked about anorexia nervosa restrictive type. I'm just going to spend a little bit of time here talking about avoidant restrictive food intake disorder, which is commonly referred to as ARFID. This is a newer diagnosis, and it represents what used to be called a feeding disorder of infancy or early childhood, although it doesn't just affect infants and children. So it is considered an eating or feeding disturbance with an example would be apparent lack of interest. There's three types of ARFID, so we'll touch on those in a second. So it's an eating or feeding disturbance that's manifested by persistent failure to meet appropriate nutritional or energy needs that are associated with one or more of the following: significant weight loss, significant nutritional deficiency, a dependence on enteral feeding, which is being tube fed, or oral nutritional supplements, and a marked interference with psychosocial functioning that isn't explained by other reasons, that isn't explained by food insecurity or culturally sanctioned practice, and that isn't related to body weight, shape, or size. So typically somebody who has ARFID is not trying to lose weight, is not concerned about being a smaller size than they are, and it's not attributable to a medical or a mental health condition. So we'll go to the next slide. So the three main types of ARFID are related to different underlying mechanisms. So the first one is sensory aversions. So many individuals who have ARFID find that they have sensitivities or aversions to texture, smells, taste. They might have a strong disgust reflex. The lack of interest here is many individuals just say they don't have an appetite, they don't experience hunger, they're not interested in foods, and they may have really specific foods that they'll eat, like sometimes less than 10 foods in terms of variety of foods that they'll eat. And then the fear of aversive consequences, there's an EpiPen here, because these individuals may have experienced an event such as having a severe allergic reaction or vomiting or choking, that involved food, that now interferes with their ability to try new foods, to eat certain foods, or to eat in certain environments. So the causes and risk factors. So the prevalence of ARFID is about 0.5 to 5% in the general population, and it most commonly does develop in infancy or childhood, but can persist into adulthood. It's multifactorial, meaning that there isn't just one known cause. However, there are some factors that might increase an individual's risk. Risk factors include being male. It's more prevalent in males, having a genetic predisposition, experiencing concurrent conditions such as ADHD, anxiety, or depression. And there is an association with individuals who have autism spectrum disorder, so ASD. Feeding difficulties are about 5 times more common in children with ASD. Sensory sensitivities and selective eating in children with ASD predisposes, is a predisposition for nutritional deficiencies. And children with ASD have been shown to have a preference for carbohydrates and aversion to certain foods sometimes. And this isn't everybody by any means, but there is definitely an association that we see. So not all children who have ASD will have characteristics that meet the clinical criteria for ARFID, but there is a connection between the two. So signs and symptoms, are similar to the other list of signs and symptoms that we saw before. Another behavioral symptom would be restriction in types of food that the individual eats, or reducing the variety of foods, only eating certain textures of foods, not having an appetite or interest. And in addition to this list, under gastrointestinal discomfort, we often see individuals who just complain of an upset stomach. They feel full often, even when they haven't eaten, and ongoing kind of reoccurring abdominal pain. So treatment options for an individual with ARFID. ARFID, just a note up here, represents 5 to 23% of children presenting an eating disorders treatment, and 2% of those admitted for gastroenterology investigations. So treatment options, consideration of the level of care that's required. Like we had spoken about before, it really depends on the clinical criteria and, physically what's happening with the individual. So similar to anorexia, there's cognitive behavioral therapy for ARFID. It's specific to ARFID, and there's a family-based therapy that's specific for ARFID. Both of these kind of support families to work with the young person to start to structure their day and structure their meals throughout the day, and also to introduce more foods kind of slowly into the diet, but with the intention of increasing the variety to be able to meet those nutritional needs. And that's where dietitian support comes in. The medical monitoring is still imperative, and offering and ensuring that the family and the caregivers have support. Treatment objectives for ARFID are to develop these routine eating patterns that typically starts with having 3 meals and 2 snacks throughout the day, to address barriers and challenges to nourishment. So to really help this young person, what is getting in the way? So we identify, is it the lack of interest? Is it the fear of aversive consequences? Is it these sensitivities? And then we really start to focus on helping them to be able to tolerate those situations. Often we'll do what we would call exposure treatment. Exposures, or if let's say an individual doesn't like certain textures of foods, we'd make a list, and we might start with the one that's the least disgusting to them, and start introducing that into their diet so they can get used to it. And then we kind of go up the list and start introducing more foods. Addressing nutritional deficiencies, and that's we would pull a dietitian in to support with that, making sure that within the foods that the individual's eating, they are receiving everything that they need in terms of meeting their nutrition requirements. And then the objective would be to work towards achieving the wellness weight and maintaining it by implementing these changes long term, and being able to maintain this variety in what they're eating day to day.
Okay, so I'm going to kind of go into our next case study, which focuses on anorexia as well, but actually on a different type, because there are kind of, various types. And so this is Lily's story. Again, like Sarah said, these are fictional characters. And so just kind of keeping that in mind. And I realize here it says Lily, but her name here is Victoria. So let's just go with Lily. I'm going to just change everything here. So a 17-year-old female, Lily, has been struggling with disordered eating patterns over the last year. Lily began to restrict her food due to body shaming comments that she overheard at school. She started skipping breakfast and throwing out her lunch at school, but always ate dinner with her parents and younger brother, so her parents would not be alerted to her new eating patterns. Once the rest of her family would fall asleep, Lily would sneak downstairs and participate in these binge eating episodes most nights, followed by self-induced vomiting, one of those things that you can do that Sarah mentioned. Another word is purging. She played on her school's volleyball team and participated in dance outside of school. Since these binge purge episodes, so eating large amounts of food and then throwing up afterward, Lily's been feeling very tired all day, has had downward trends in her school grades, and decreased energy for volleyball and dance. 3 months ago, her mother overheard her vomiting in the bathroom after dinner one night. Seeing how parents had prior concerns about her weight loss and changes in behavior, they took her to their family doctor. After learning Lily had not been getting regular periods, she had been purging daily, counting calories, her doctor diagnosed her with anorexia nervosa, binge purge subtype. So kind of similar to Sarah, I'm going to take you kind of through that, criteria for diagnosis, symptoms. My kind of case study, because being a dietitian, will focus more on that nutrition piece and really giving a really good look at that, whereas Sarah was able to focus more on those treatment modalities. Okay, so as we said before, the criteria for diagnosis, you're going to notice there's a lot of similarities with treatment, maybe some symptoms with the restrictive type. The difference here is that for diagnosis, there is a restriction of energy intake. So a very, very big discrepancy between energy needs and what the youth is actually receiving from food. An intense fear of gaining weight, a distorted body image. So again, not actually being aware of, what their body truly looks like, and really thinking that people are having a very negative kind of perception of what their body looks like. And here's where it differs. There's that binge eating and purging, whereas in that restrictive type, there is the only type of sort of compensation would be that exercise. But when I say purging, it could be throwing up. It could be the use of diuretics or laxatives as well. So just something to keep in mind. That's really the main difference between those two types. So very similar. There's so many symptoms across the board. And you'll notice a lot of them are the same. Some of them are a little bit different, but they are, split up into different categories. So the green ones that are highlighted are the ones specifically that Lily kind of has been experiencing. So those eating patterns, so that restrictive eating, the binge eating, and the purging behaviors, she has all of those things. Her physical symptoms, she's experienced weight loss, amenorrhea, so again, like that kind of loss of period, or maybe her periods are haven't been as regular as they would have been, lots of that fatigue, GI distress. So it's important to note that a lot of, those struggling with an eating disorder are going to have a lot of constipation or gas or bloating. And a big reason for that is because when our digestive system and our intestines are not used to receiving food and digesting food and doing all of the kind of movements of the muscle, because the digestive system is a muscle, it kind of atrophies, it kind of stops working. And so that kind of feeling of losing that ability to say, I'm hungry, or having that loss of appetite is very normal. And then that can lead to, again, parents potentially thinking, maybe there's a stomach issue here. Maybe they're not eating because they're constipated or they're bloated. And so it can kind of be this vicious cycle. So I said before, she's experiencing constipation. She's experiencing all of these things. So that's kind of something that I wanted to mention. She has that distorted body image, that social withdrawal. She doesn't really want to be with her friends. She doesn't she's participating in sports, but doesn't really want to be there. And then there's another key piece here, this secrecy around eating. So I had mentioned that Lily is not only is she eating large amounts of food, but she's doing that in secret. And that comes with often lots of guilt and shame. So not wanting to eat around people, but but also then not wanting people to judge how much she's eating at one time. And so there's that other very, very big piece, is that intense guilt and shame around eating so much food at one time. So there's kind of different treatment types and length, of course. And there's different, like Sarah said, it's a multidisciplinary team. It's making sure there's comprehensive assessment, comprehensive treatment. So medical monitoring by a primary care provider, or maybe there's a nurse in a program, depending where you are, making sure that, lab work looks good. So looking at maybe some vitamin and mineral deficiencies. What about your electrolytes? Making sure those are all in kind of, good standing. Even like the cholesterols, the blood sugars, because when we don't have proper nutrition, these can really kind of start kind of going a little bit wonky on us. Blood pressure is very important as well. Sometimes they'll check to see what that difference is between standing and sitting to kind of see the severity of symptoms potentially. So that monitoring of weights. So I wanted to mention that at the beginning, a lot of the time for treatment, Sarah had mentioned before that it's not always about a number, but at the beginning, sometimes we do need it to be about a number, and the term wellness weight came up. And so what that really is going back to what we think is a weight at which that youth was thriving. So she talked about that growth curve. What weight was that person at the growth curve? Were they on that 50th percentile? So what corresponding weight was that? What weight were they when they had the most energy, when they were getting their period, if they have that female anatomy? And so it's important to note that wellness weight could be a treatment goal weight. It can be named a bunch of different things, but it's a weight that is always going to be assessed and changing depending on how they're responding to treatment and how they're improving in their recovery. So there's kind of two ways to do weights as well. Some youth will be okay knowing their weight. So let's just say they come in and they're like, yeah, I'm good with knowing my weight. Parents are on board. Therapist thinks everything is okay. Then they will know the value. And then there's our blind weights, which I would say a lot at the beginning will need, where they'll be weighed, but they won't know their number. They might know whether they're going up or going down, but typically it's very triggering for them. And so that's not something that might be shared. So like I said, there's a lot of that education and counseling as a dietitian on that nutrition piece. So one of the goals, talking about working within a multidisciplinary team, is also really to support the work that is being done with everyone else, specifically the mental health clinician or the therapist. There's often a lot of overlap between those two roles because we're both working on maybe some food goals and kind of reintegration of certain foods. So what we really want to focus on with kind of that renourishment is a gradual reintroduction of food in a very structured manner to normalize eating patterns and minimize binging tendencies. So I'll kind of break that down a little, but typically, just like as like physiology works, and I think we can all sort of maybe, like we probably have all had these moments. So when, as human beings, our main source of energy is actually coming from our food. And so when we don't feed our body regularly throughout the day, regardless of, our gas tank is now on empty, our energy, our battery is low. And so what happens is that once we slow down and say, we're busy at work or whatever that might be, you come home and you're like, oh my gosh, I'm so hungry. I didn't realize I was so hungry. There's a lot of hormones that start to go and you kind of get into this caveman mode or starvation mode where part of you really cannot control a lot of the cravings that you're feeling because you haven't fed your body all day. And now your body is screaming out to you, you need to feed me and you need to feed me now. And because of this, a lot of the times the binging episodes that happen, especially in those with anorexia, binge, purge, is choosing those higher energy foods that might make that person feel even more guilty for eating them. So maybe they're going for pastries or fried foods or something like that, because our body's just trying to get as much energy as possible. And so what can happen is we sort of get a little bit out of control, not to anyone's blame. It's just biology kind of taking over and trying to kind of make up for the food that we haven't eaten for the rest of the day. So getting them to understand that eating every 3 to 4 hours, eating and making sure that they're getting the proper nutrition is going to help really, really. It's not going to, completely get rid of everything, but it's definitely a piece of the puzzle in addition to kind of all those other things that we need to consider in terms of their, like, maybe trauma or other mental health challenges. Mechanical eating. So with progression to relearning, listening, and honoring hunger and fullness cues. So mechanical eating, I mentioned before, a lot of the times, when there are eating disorders present, it's a lot of I'm not hungry, because the body gets really used to not eating and it's very adaptable. And so at the beginning, it's really like eating when you're not feeling hungry, which I think, it is a very, very hard thing to do. But eventually, once we start to refeed and patterns become regular and there's regular meals and snacks, what happens is it shifts to really honoring and understanding what does hunger feel like in their body and what does fullness feel like. And so moving toward that maybe quote unquote intuitive eating, if anyone's ever heard of that, but really honoring again, like, what do I want? What does my body need? What's going to be good for me? And how do I know when I'm ready to eat and when I need to stop? That's kind of toward the end, but that's what we're progressing to. And then obviously understanding the fundamentals of nutrition to support decision-making that will nourish mind, body, and soul. So really understanding the roles of the basic nutrients. So something like protein and understanding why that's important for us, and our muscles to have, or understanding why fat is important, right? A lot of the time that basic knowledge around what our nutrition actually provides for our body is not there. That's not typically something that they're teaching really in-depthly at school. So again, some other things in terms of coping strategies and psychotherapy. So again, I think Sarah kind of went into this a little bit more than I will because she's the therapist. But some coping strategies could be, developing skills to manage stress and anxiety, whether that be stress and anxiety that's going on at home or at school or anything else. Encouraging other hobbies that promote self-esteem and body positivity. So even say physical activity or movement, like really getting the joy in movement and not it being something that they're doing just because they feel like they should or that they need to like burn off any energy, but really finding, what's going to help them, like feel better about themselves. And you'll see the therapies are very similar. So that family-based therapy, relationship with food should improve. So again, it's being able to expand the variety of foods. Oftentimes the youth will have lots of, they're called fear foods or safe foods. So fear foods might be foods that they're like, absolutely not, like I am never going to eat those foods again. They scare me. Typically lots of snack foods, fried foods, sweets. And then they have their safe foods, which they're like, I can eat this because it's not going to cause me to gain weight or it has the least amount of calories. So often it could be fruits, vegetables, oatmeal is a big one, yogurt, kind of all your typical, what you would call maybe healthy things. And so it's really important for us to kind of move away from that and expose them to the foods that do scare them, but in an appropriate way. And that's something that Sarah definitely helps with in terms of like therapy and exposures to different foods. That cognitive behavioral therapy, so a focus on changing those negative thought patterns, that emotion-focused family therapy, so that's really incorporating the caregivers and the family members. And then there could be also some group therapy. So maybe there's support groups, depending on, again, what type of treatment the youth is doing to foster a connection. Okay, so obviously the length of treatment in any program is really going to vary on an individual basis. But for Lily, there's kind of, this is what I would expect for like short term, ideally 1 to 3 months. We're stabilizing her weight, we're establishing that regular eating pattern, and we're initiating the therapy piece. And then more longer term is achieving that wellness weight, improving the body image, developing effective coping mechanisms, restoring, her regular period. And again, this is really going to depend on the motivation from Lily herself, but also from her family, as well as the supports that she's getting around her. Okay, so I'm going to talk a little bit about binge eating disorder, just for a few minutes. And this is kind of, I would say also a newer kind of eating disorder that has come up. And I don't know if a lot of people know that binge eating disorder is an actual disorder. So the definition is it's characterized by recurring episodes of eating large quantities of food quickly and to the point of discomfort. So it's important to note this is without any purging behaviors, okay? So we're just eating lots and lots and lots of food. And the key features could be eating more rapidly than normal, eating until feeling uncomfortably full, eating large amounts when you're not actually physically hungry. And there's lots of disgust, depression, or guilt after overeating with oneself and the way one looks. And these feelings typically like persist. It's not just, it's a thought and it goes out of your mind. It's kind of persisting for a longer period of time. The Diagnostic and Statistical Manual of Mental Health Disorders, we mentioned the DSM-5, that's what it stands for. So it has to be recurrent episodes of binge eating, marked distress regarding binge eating. So occurring at least once a week for 3 months. And again, there's no regular use of inappropriate behaviors that we're trying to compensate for what we have done. So vomiting, exercise, laxatives, diuretics, things like that. So again, these causes and risk factors. So the biological, there could be a genetic predisposition, there could be imbalance hormones in the brain and neurotransmitters. Psychological factors could be emotional triggers are a really big one. So if there's stress, if there's trauma, again, if there's any other type of like mood or anxiety disorders present, so low self-esteem. So our diet culture and societal pressures or trauma-related experience. And I think this goes for really all of this, like all of eating disorders. Our culture that we live in, unfortunately, it's very hard to differentiate at this point between what's disordered eating and what's considered normal. And so sometimes like restricting food is what just people are doing right now. And it's normal to be counting calories. It's normal to be cutting out carbs just because everyone around us is doing it. And so it's important to think about the environment, not only at home, but at school. And some things are going to be in your control, some things are going to be out of your control. And so it's just important to know that it's really hard to get away from that diet culture. I think it's more understanding that it exists and like, how do we deal with it? The one thing that's not on here that I mentioned last with the binge purge is the irregular eating patterns. So oftentimes binge eating episodes happen, or binge eating disorder can happen because someone is going all day without eating. And then that again triggers that kind of caveman brain to go off. And it can kind of all meld into all of these things, but just even regulating eating patterns, again, it's not going to completely take it away, but it is going to help. So again, signs and symptoms. So fluctuations in weight. It's not like a certain look. Some people might be living in a larger body. Some people might be in a smaller body. Again, hoarding food, so eating in secret, a preoccupation with food and eating, lots of distress around eating habits, and still that same like withdrawal from social situations involving food. So there's some very similar things going on. So similarly, there's some treatment options. There's the cognitive behavioral therapy. There's something called interpersonal therapy. There may be some medications that can help with reducing binge eating episodes. And again, that nutrition piece. So developing a balanced, structured eating plan. Also, even with food exposures, understanding that restriction can lead to overeating. So it's like a kid in a candy store. If you tell a kid you can't have that, the more they're going to want to eat it, or the more they're going to want to have it. But if you say like, yeah, you can do that, or you can eat this, eventually that novelty sort of wears off. Coping strategies could be mindfulness and stress management, like meditation, deep breathing, again, support groups. So surrounding yourself with others who understand your own challenges, and healthy lifestyle changes. So regular physical activity, movement you enjoy, and focusing on that overall wellness. Okay, I'm going to pass it over to Sarah.
Yeah, thanks, Zippy. So I'll just talk briefly about the levels of treatment options that we have referred to throughout the presentation. So there's 3 tiers of treatment options available. And the first one we'll look at the slide for is inpatient. So this is the highest level of intensity for somebody who requires being admitted into the hospital for treatment within the hospital. So this would be for an individual who was medically unstable, so whose vitals were abnormal, who was at a high risk because of their eating disorder. It could also be for an individual who has tried other forms of treatment or other lower levels of treatment and hasn't been effective and has been deemed to require a higher level of intensity. Length of treatment will vary with the individual and with the treatment program. There would be ongoing medical monitoring within the hospital, meal support and refeeding within the hospital. So the individual would have all of their meals supervised, sometimes mostly in a group setting within the hospital. And again, a multidisciplinary team would be involved. The next level of treatment down from inpatient would be day treatment. So a day treatment setting, typically somebody will move from inpatient to a day treatment setting. We'll just flip to the next slide. So the day treatment is typically for an individual who is medically stable, but still needs that ongoing support with meals. Usually there is a school curriculum present. It's usually 5 days a week, maybe Monday to Friday. So the individual will be at home on the overnight and on the weekends, and then is spending full days typically within the day treatment program. And then the least kind of interventive would be an outpatient program. Sometimes individuals do move within these 3 treatment programs, depending on what their needs are. I mean, ideally, we'd want somebody's recovery to kind of, move along, but sometimes there's challenges, sometimes there's ups and downs within treatment. So an individual may need to kind of move along this continuum based on what their clinical needs are. An outpatient treatment setting would typically be an individual living in their home with their family. They're medically stable. They'll have some medical monitoring. Usually that might be done by their primary care provider. It might be done as part of their program if there's a nurse or physician in their program. And typically they would have weekly sessions or with a dietitian, and they'd be seeing a mental health professional once or twice a week as well. And this can help individuals kind of move back to school, move back to kind of their, regular life and transition to that life. If they've been in a higher level of treatment, it can help them with that transition. There are strong recommendations for individuals to receive the lowest level of this tiered treatment, so the least invasive type of treatment that based on clinical needs, but it's more optimal for an individual to kind of be in their community, be at home receiving treatment if it is effective and if the higher level isn't required.
Okay, so we just have like a couple of more little pieces, but really we're getting to the end. We've mentioned the multidisciplinary team multiple times. So it's obviously a very, very important part of any treatment. But this is just kind of like a visual of, kind of why it's important and how everyone is connected and what it represents. So here, obviously, there can be, again, others involved in kind of this maybe circle of care, multidisciplinary team, but the client is always at the very center, right? Client-centered, family-centered. That's who we're trying to help. So typically we have some sort of mental health clinician, whether it's a social worker, a psychotherapist, a psychologist. We have a registered dietitian and some sort of primary health care provider. So some might have, most people have a primary care provider, but then there might be like a nurse involved or something like that. So again, there's individual therapy, family therapy, that nutrition support from the dietitian, regular monitoring to make sure that we're not missing any severe symptoms and anyone who is medically unstable. So we actually have, and I think everyone does get access to these slides. So National Eating Disorder Information Center is a really great website to get all eating disorder information, but both NEDIC and Eating Disorders Ontario, this is actually a PDF, provides a really extensive list of programs, both like in the community, in a hospital, within Ontario. So if anyone is interested in learning more about all of the programs that are out there, you can access both of these lists and see kind of what is available. There's a lot of different options. And then just some key takeaways from our presentation. So eating disorders are serious, complex mental health disorders that affect emotional health, physical health, and psychosocial well-being, and they're associated with severe mental health and physical risks. They do not discriminate. They can affect individuals of all ages, genders, ethnicities, socioeconomic backgrounds, and all body shapes, weights, and sizes. The most important thing to remember is early intervention and family support is very critical in a successful recovery. And I'm using the word recovery very loosely, but recovery really does run on a continuum. And sometimes it can take a very long time to, there's always that opportunity for relapse or going backwards. And so again, I think it's always having that in mind that there's no one way that recovery has to go. It just really looks different for everyone. That's it for us.